So thank you so much, everyone, for joining us today. My name is Emily McCall. I am the project coordinator with the Michigan Opioid Collaborative. We are pleased to have Dr. Chris Frank here with us today. Dr. Frank works with the U of M Department of Family Medicine. MOC offers a monthly webinar series, and so we're excited to have him presenting this one. For those who are interested in getting information on future webinars, please be sure to give us your email in the chat box. If everyone could also introduce yourselves in the chat box so we know who's here with us today, that would be great. In terms of housekeeping items, if we could all keep our microphones and videos muted while Dr. Frank is presenting, feel free to enter questions in the chat box as we go. We can stop for questions. We'll also have time at the end for questions. You'll be getting a follow-up email with information from us afterwards with a copy of the slides as well. So thank you, and I'm going to go ahead and let Dr. Frank get going.
All right, excellent. Are you able to hear me okay, Emily?
Yes, we can hear you.
Perfect. Well, thanks everyone for coming today. Still a weird world delivering stuff remotely, but I'm glad that we have people from around the state today to talk about an important issue. I will admit that when Emily asked me to give this presentation, I actually said no a few times, as she knows, because I think it's always difficult to talk about demographic populations without kind of falling back on stereotypes and generalities that sometimes don't help and sometimes reinforce some of the biases that we all have. So with that little disclaimer, I'm going to go ahead anyways. For people who are looking for CME, here is the activity code, and that'll be in your handouts afterwards. So we have a few learning objectives today. One is just to describe the epidemiology of substance use disorders in rural populations. We're also going to talk about some demographic and social factors that contribute to substance use in rural communities and explain some of the opportunities and challenges of preventing and managing substance use disorders in rural settings. And I think often we talk about a lot of the challenges, but I don't think we spend a lot of time talking about some of the opportunities, and I think that's actually an area where there are a lot of them. My background is I'm a family doc by training. I trained to work in smaller communities. I spent the last 8 or 9 years working out in a rural part of Washington state, where I did a mixture of primary care, working at FQHC, but also ran our health department with a harm reduction program, syringe services program, and we spent a lot of time expanding evidence-based treatment for some of our kind of toughest hit parts of our region. So I was going to say that I have no conflicts of interest, which is true, but I do have a disclaimer. And the disclaimer is really what I talked about at the beginning, which is, you know, anytime you talk about specific types of communities, there are going to be some biases and stereotypes that can obscure some of the real differences between communities. And I think the reality is that rural counties, rural communities are very diverse. There are counties that are growing as fast as any place in the country, and then there are counties that are shrinking dramatically. Just like there are metro areas that are growing super quickly, and then those that are shrinking, some of them even in Michigan. You know, I mean, Wayne County is, in my mind right now, is an example of a county that is just like contracting incredibly. Similarly, around some of the other social determinants, you know, there are counties with really strong education systems, and there are counties where a majority of residents don't finish high school. So additionally, when we talk about, you know, some of the economic drivers of substance use disorders, there are really wealthy counties, and there are counties that have some of the highest rates of concentrated poverty in the country. So, you know, I don't want to reinforce any of these stereotypes, but I want to talk about this issue today because I think there are some real advantages that smaller communities have when it comes to helping patients with substance use disorders. And so let's get into it. And I can't see the chat box, so if anybody has questions or whatever, I think Emily will probably jump in and stop me. So, you know, when we talk about what is rural, you know, the standard demographic definitions are different depending on what government agency you work for. The most common one that a lot of studies use is the Office of Management and Budget, and that's these sort of 6 levels of urban-rural classification that the CDC use, and they kind of clump the biggest 4 together and call it urban or urban-suburban, and then the 2 tiny ones, micropolitan and non-core counties, get grouped together as rural. But in a lot of ways, we all bring our own experiences to the word also, and you know, it's probably like pornography. You know, in general, you know when you see it, and if you think that an area is rural, you're probably right, and it probably ends up matching some of the definitions that the census, OMB, and USDA use. I like this map because it gives the visual of rural counties in the U.S. You know, only about 15% of the population live in non-metro counties, but those counties account for 70+% of the land area. And if you look in on our state, Michigan here, you know, essentially all of the northern lower peninsula and all the UP fall into the non-metro or rural category. So again, back to my original disclaimer about generalizations, but on average, there are a few things we can say that are true for many rural communities, even though there are exceptions in all of these categories. In general, they've had stable or declining population over the last 20 years. Job growth in a lot of communities has been stagnant for adults in that what they call that sort of prime age, 25 to 54 demographic. And educational attainment has improved in pretty much all rural counties since, you know, like 70s, but it still lags a lot of metro areas. And poverty rates have increased during the housing crisis, 2008, and that time, and then they improved. And you know, I think it's going to get tough here again with COVID. But even with those changes, there's always been a persistent gap between rural and the more metropolitan counties. I like this picture because it shows population gain or loss since 2000 among rural US counties, and it sort of highlights like how variable it is. And so, you know, the majority of rural counties in the Northeast and the Midwest have lost population since 2000. And then parts of the South and the West have gained population. And it's even interesting, I think, to look at some of the regional differences in Michigan. You know, if you look at, I don't know, hopefully you guys can see this, like, so that in northern lower peninsula, it's really pretty stark east and west side difference, and those of you who live up there know that and feel that. And if we look about in the Midwest in general, the communities that are shrinking the fastest are often those that have a strong reliance on agriculture. And so although rural population here has grown a little bit since 2000, the majority of populations in individual rural counties have not. So essentially 50+% of all rural counties have lost population since 2000. And job growth and wage growth has also been really uneven. So, you know, you can see population growth here in urban and suburban areas, 13–16%, rural, tiny 3%. And then if you look at prime age employment, it's increased in urban, suburban areas and declined by 11%. And this is in a, you know, the prime employed demographic, 25 to 54-year-olds. And if you look at poverty rates by metro or non-metro areas, kind of doesn't really matter what of these different definitions you use, there's pretty much always a persistent gap in poverty rates. But as you can see, I mean, the gap was, you know, much larger in the 50s and 60s. And so it narrowed, but that gap is still there with non-metro areas in general having a higher poverty rate than metro and suburban areas. And the reason I bring all this up is obviously we know that many of these socioeconomic factors contribute to risk factors for developing substance use disorders. Oops. So this is looking at poverty rates by race and ethnicity across metro and non-metro areas. And I think it's interesting, and I'm actually going to talk quite a bit about race today and the way that has played into how we think about rural substance use disorders. But what I just wanted to show here is that there's a poverty gap pretty much everywhere across all races and ethnicities, but the gap is largest for African Americans and American Indian Alaska Natives. And I know many of you work with tribal or are part of tribal communities or work with tribal communities. And we had 4 tribal communities in the county that I worked in last. So I spent a lot of time with people working in American Indian Alaska Native areas. And I think that probably matches what a lot of us have seen. The last slide in sort of this little demographics, I just think is really interesting. Let's see here if I can. Uh-oh, there we go. So this is looking at disability rates across the US. And we know that disability is also a risk factor for substance use disorders. And I just want to highlight a few areas where disability rates are really high. West Virginia, Kentucky, Maine, parts of the South in general. And I think if you look in Michigan here, you also notice these higher disability rates in the Northern Lower Peninsula and the Eastern UP. So when we think about SUD use in rural, small metro, and large metro areas, I think there's a lot of nuance to some of this. So first of all, again, go back to my disclaimer, like that there's a lot of diversity, and this is speaking in averages. But there are some things we can say in general. In general, rural communities have higher rates of alcohol use, especially binge drinking by youth. They have higher rates of tobacco use and higher rates of methamphetamine use, even though it's small and hard to see. Small and large metro areas, so that would be like the orange and the gray, have higher rates of marijuana use and higher overall rates of illicit drug use. And overall opioid misuse is pretty similar across a wide range of communities. Essentially, there are communities of all sizes that have high, medium, and low levels of substance use. So, you know, obviously a lot of this is old news to most of us. You know, we know that the rates of drug overdoses have increased since the 1990s and then declined for the first time in a long time just here in 2018. So if we look at rates of drug overdose deaths over time, in general, historically, the overdose death rate in urban areas, metro areas has been higher than rural areas. Obviously, there is this uptick in both areas, and you know, and then rural communities really took the lead, I guess, for a little while here. But that trend has switched back to closer what it has been historically, which is more overdoses in larger communities, and that's age-adjusted rates. So this bump right here in rural communities corresponds to increase death rate, particularly among white men, sort of middle-aged men. That's sort of the deaths of despair that Case and Deaton talk about. And so, and it was, so prominent that it actually led to a decrease in life expectancy during that period. And so it's gotten a lot of attention. So bottom line is that overdose deaths are not really a rural or urban issue. They've increased across communities of all sizes, even though maybe the causes of overdoses have some nuance about based on location, I guess. So this is a paper looking at the specific causes of overdose deaths broken down by urbanization levels. And so this kind of clumps the four big things in the green bars, and then the two smaller, so micropolitan and non-core counties into the rural areas. And I think there are a few interesting things. It probably matches what a lot of us see in practice, which is that, in general, when we're talking about natural and semi-synthetic opioids like hydrocodone, oxycodone, overdose death rates to those are higher in rural communities. And when we talk about things like heroin or the synthetic opioids, mostly fentanyl and fentanyl analogs, those rates are higher in the four largest urbanization levels. And then I know, I think we're entering sort of the fourth wave of this epidemic now, and we're seeing more deaths associated with stimulants. I'm sure that matches what many of you are seeing in practice. And the rates of overdoses that are also associated with psychostimulants, so mostly meth, are higher in rural areas, and cocaine is more prominent in the larger communities. So I wanted to dig in a little bit more on some of the race and ethnicity issues, because I think sometimes this gets categorized as like essentially a white opioid crisis, like a rural white opioid crisis, and it's just really not true. And so this is looking at age-adjusted poisoning mortality rates. This is in Michigan, 2017, 2018. So Black rates were the highest in 2018 and increased from 2017. And then you have non-Hispanic white that actually decreased a little bit in 2018. And then everyone else, where there's also a decrease in 2018. And if you look at, if you just strip out the other causes and just focus in on opioids, again, you see a fairly dramatic increase in overdose death rates due to opioids in African-American community, and small decline in non-Hispanic white and other communities. This is not really just a Michigan thing. Minnesota is our friendly neighbor to the west. They actually have fairly low overdose death rates compared to many other states, but they have very persistent race and ethnicity gaps, which is not surprising from what we've seen in Minneapolis. That's sort of a manifestation of a lot of this. And in Minnesota in 2016, African Americans were 2 times more likely to die of a drug overdose than whites, and their American Indians, Alaska Natives were almost 6 times as likely to die of an overdose than whites. So I guess all that is like a long way of saying, so like, why does rural and white drug use get so much attention? And I think honestly, it's really comes down to where the current overdose crisis started. And I guess it's a little tongue-in-cheek to say 2 words, West Virginia, but I do think that has a big part of it. And the more you follow sort of media discussions of overdose deaths, the more obvious it becomes that. So when headlines talk about the changing face of the epidemic, what they really mean is that it is impacting white people. And so I pulled like a few things off of some different, this is an NPR story. This is from a recovery center talking about the new face of opioid use disorders in the US. This one is a march that happened in Las Vegas, and this is a quilt. And what you see is that a lot of the media attention is focused on deaths among white people from substance use disorders, even though in most places the rate of death is higher for African Americans. So when we're trying to figure out like how we got where we are, I think many of you have seen this before, but this really kind of talks about the different ways that the opioid crisis and other substance use disorder crises have sort of hit us in these waves. And, you know, initially it was this wave of prescription overdose deaths, and as we pulled back our prescribing, many people switched to heroin. That's the yellow line, where we started to see that rise in heroin deaths. It was followed by all these deaths due to synthetic opioids, especially in our metropolitan areas. So that's mostly fentanyl and fentanyl analogs. And so, and now we're into this fourth wave that, you know, is usually often involves stimulants also. In this first wave of high risk opioid dispensing and high deaths, it really was in this sort of opioid belt that stretched from West Virginia, Southwest Virginia, Kentucky, and that swath there that's on those maps included 18 of the top 20 counties in per capita opioid deaths nationwide. So essentially death rates went through the roof there, and those are predominantly white counties. And they all had death rates that were, you know, close to 40 deaths per 100,000. And now overdose death rates have caught up in all these metro areas and surpassed the average overdose rates in rural areas. But because of this sort of historical, where this started, some of the hardest hit parts of the country are still in smaller communities. And so even though on average the overdose epidemic has never really been specific to rural communities, it feels that way sometimes. And as we've looked more, as you can dig into it now, ruralness or urbanness doesn't really seem to be an independent risk factor for overdoses. So there are lots of hypotheses about what sort of social factors contribute to substance use disorders in rural populations. And many of you, I think, have experienced or worked in communities where you've seen some of these. And they're not true everywhere, but a lot of them were true in the community I was working in Washington, probably some of you too. We had essentially very unsafe prescribing that led to greater availability and early experimental use for lots of young people. And then a lot of the young people who could get out, got out. And it left some economic decline, also a concentration of young people who are at really high risk because they were underemployed and stressed. And then, and there are often some pretty tight kinship and social networks that are tighter in some rural communities than other larger communities. And we've seen how this leads to fast diffusion of both substance use, but also infectious disease. I always think of Scott County, Indiana, as in my mind as like a, you know, very, very rural county that had essentially no HIV. You know, people got tied up injecting the Opana, and boom, in like a year they had, you know, a couple hundred people with HIV, just because it was a multi-generational community with lots of tight kinship and social networks. and I don't know about you guys, but I always think of opioid prescribing that it's improved a lot. I used to spend a lot of time doing like academic detailing where, you'd go out to a practice and talk with somebody to try to get them to rein things in or adjust how they were doing things. And there's no doubt that things have improved. The peak of prescribing was 2012, but the rates are still way higher than they were in the 90s. And the decline in unsafe prescribing hasn't been uniform. And, I know that the decline can, rub some people the wrong way because we know that the declining prescription rates didn't lead to a corresponding decline in overdose death rates. But this is from NPR. I just pulled this like a week or two ago. So there are still many counties, mostly in rural areas, where opioid prescribing is still way higher than the peak in 2012. And you can see it's those red and pink areas. Those are ones that are, up to 150% of the peak national rate in 2012. And so you see it's in the South, in West Virginia still, Virginia. And then if you zoom in on Michigan, some of it's still in northern Lower Peninsula, a little bit on the east part of the UP. So even though we think of that as essentially, I used to think of it as essentially a resolving issue, but there are still areas where there is increased early access for young people. So I think we talk about a lot of the challenges that rural communities have, and I'm not discounting these because like the challenges are real, and I felt them. I'm sure many of you felt them. I put transportation on the top here just because it's such a huge problem. So many people have lost their driving privileges or don't have access to a car or gas money, limited public transportation options. I'm thinking of a guy that I take care of right now who lives on this like farm place. It's kind of a weird, this guy takes people in who are struggling and gives them a place to stay in exchange for working on his farm. He's out in the middle of nowhere and it's working for him. He's trying to avoid his social circle that often triggers his use, but he's allowed to borrow a car like once a month. And so, it just makes it really hard to engage with a recovery group or get a job or do any of the other things that are gonna help move him along on the path to recovery. And so, when I used to work out in Washington, I would have people that would take the bus, 3 hours to get to a methadone clinic. And that's just not conducive to a really robust recovery environment. I think the other challenges are ones that we know about, limited access to evidence-based treatments, especially the medication treatments for opioid use disorder that have the best evidence. So methadone, buprenorphine, and now some long-acting naltrexone. And then the ongoing challenge of some high-risk prescribing. I don't need to tell this group that, methadone and buprenorphine have the strongest evidence for improving outcomes and decreasing mortality when it comes to treating patients with opioid use disorder. But, federally licensed methadone programs are just not an option for a lot of patients who are in rural communities at a distance. You can see in Michigan, and I think there's 2 in Gaylord maybe, but really there's not a lot. And there's huge swaths of the US where there's nothing within a reasonable driving distance. And, like I said, I had multiple patients who, had sort of not done well in an outpatient-based buprenorphine program who ended up in a methadone program. And, 6 hours on the bus, 3 hours there, 2.5 hours there, get their dose, 2.5 hours back. And essentially, it kept them alive, kept them out of trouble. But they really, it was not a great solution. We know that even though things are improving, the percentage of substance use treatment facilities that offer medications for management of opioid use disorder increased from 20% in 2007 to 36% in 2016. I don't have the newer numbers. I'm sure it's continued to go up. But, even in 2016, only 6% offered all 3 FDA-approved medications. And so this is the methadone line here, which is stable. You can see when naltrexone started coming on board, buprenorphine got up, at this point got up to about 20%. And here's any medication management options. And, I put this in here because we know it's really important, but this is not specific to rural areas. There are treatment facilities all over that have medications and don't. And there's not a strong rural-urban split. And we know that outpatient-based addiction treatment with buprenorphine outside of treatment facilities, so in primary care or other settings, is expanding slowly, but still it doesn't meet the needs of patients in most demographics in most communities. And this one always surprises me in the sense that I would sort of think that in general evidence-based treatment would automatically follow high-risk patients, but that does not seem to be true. This is looking at death rate, and then this is looking at facilities, substance use disorder facilities that offer medication management. And, you still see that there are places like Kentucky, Ohio, West Virginia, who have very high death rates and still don't have, still only have 50% or less of facilities that have some way of getting medication management for the patients. The need for additional treatment is often self-identified by rural counties. So, the last place I worked in rural Washington, if we surveyed on this, substance use and lack of treatment would come up as the top issue every time we did a community survey or community health assessment, anything like that. And it's similar in parts of Michigan. This is from 2018, looking at percent of local government respondents who thought there was an unmet need for drug treatment in their jurisdiction. And you can see it's, quite high in some regions of the state, up in the 60 to 90% range, but it's a patchwork, and it's obviously highlights how local a lot of these things are. And I mentioned ongoing high-risk prescribing is a challenge for some areas. I thought I'd just show the data for Michigan in a different way. And we know that decreasing prescribing doesn't automatically lead to fewer people with opioid use disorders. But we do know that, early exposure is an independent risk factor. And so you combine higher rates of binge drinking, tobacco use, and more readily available prescription opioids, and all of those contribute to a higher risk environment for young people, especially if they have limited education and employment opportunities. And so the darker numbers are higher prescription rates, and this is prescription rate per 100 persons, adults. So we still have counts that are over one script per person per year. So a lot of that sounded kind of negative, but I really do think rural communities often have unique resources that that a lot of other places don't have. There are things that are absent, transportation being one, some specialty penetration being two, although a lot of this, as everyone on this call knows, a lot of this can be delivered in primary care and substance use disorder treatment settings that don't require subspecialty level care. Another thing that's missing a lot of places, that's not unique to rural communities, is adequate housing. But there are also there's a lot of built-in resiliency in a lot of rural communities. Community mental health is present in most places. Lots of federally qualified health centers that have sort of a mission to taking care of underserved, and often have alternate revenue streams that can go towards treating patients with dual diagnoses. 12-step programs are almost everywhere, and although everyone has different opinions about all kinds of recovery programs depending on their own experiences, one of the good things we can say is that, you know, the recent Cochrane review showing that in general, 12-step facilitation can be as good as anything else for alcohol use disorder, and very present really in even some of the smallest communities. We also know that there's expansion of drug courts, and then there are all of these non-medical places that are smaller and a little bit easier to deal with than some of the big places in more metropolitan settings. That local public health departments as places that have often some deep community ties and some additional resources. And the way I think about it, and this sort of matches my experience, and I hope some of yours too, which is, you know, the disadvantages of treating substance use disorders in rural communities often relate to lack of resources, or lack of specialty care, or lack of wraparound services. But I think those same issues are present in high-need communities, whether they're rural, suburban, or urban. But the advantages of being in a rural community, I think a lot of times outweigh those, in the fact that, you know, a small number of people can really drive change in a community. And, you know, I don't want to make it sound like that's easy, but when there are fewer people who need services, sometimes it takes less progress to make a big difference. And often small amounts of success start to feed on themselves. And, you know, I think when communities can feel things moving in the right direction, it can generate a lot of positive energy. And on this slide, I just put up, you know, some of these things about how many people do you really need to convince to make a change. And I can just speak for, you know, my own experience in a smaller community was, you know, if you want to start a medication for opioid program in a local jail, sometimes that has to go through like incredible layers of bureaucracy and complexity in a bigger place. I know that in our community, we had to convince one person. That was it. Same with hospital leaders. And I know, for example, University of Michigan, giant system, 70,000 patients, huge ER. They have been trying to get buprenorphine prescribing in the ED for years. And it is still somewhere in a committee of people that needs to be signed off on something by somebody. And so anyways, our community, you know, we needed to convince one person. And sometimes that makes all the difference. Similar with high risk prescribing. If you dig into the data in a lot of smaller communities, a lot of the high risk prescribing is driven by only a few outlier physicians or APPs. And, you know, while in some ways that's disappointing, the other way of looking at it is it's a lot easier to fix that than a situation where there are hundreds of high risk prescribers in a more metro area that doesn't have any resources to reach out to those people. And I put the same thing on there at the bottom around drug courts. And I have this around drug courts. I'm not going to read this. I only put it on there in case anybody on this call ever needs this, because the National Association of Drug Court Professionals has been very clear. They had this unanimous resolution, these board of directors, that drug courts, you know, should in general permit the use of medically assisted treatments, and it should be guided by input from physicians with expertise in addiction psychiatry or addiction medicine. That doesn't mean that drug courts have listened to this guidance always, but there's going to be ongoing pressure to get drug court participants into evidence-based treatment. And in a similar way to the other sort of ER or these other smaller things, often you got to convince like one judge or one, you know, intake coordinator. And I just think in general, You can often do those as personal interactions with people that you know and work with and live close to. And it's just, I think, in some ways easier to do than in big settings where it's more complicated. One of my last two slides. I wanted to talk about stigma, but I left it blank because we all know it's a huge problem. It's not a problem just in rural areas. It's not a problem in urban areas. It's a problem everywhere. And I've not been able to get my head around the problem. So, you know, I don't know of any evidence-based treatments to decrease stigma. I know there are a lot of people working on it. And all I can say is, you know, I know this just from coming to other of these webinars, I know that the people on this are on this. So, you know, all I can say is, you know, I just encourage everybody to continue to do their best to treat everybody with empathy and respect, you know, the same as we would want when we're in their shoes. So my summary slide is that, you know, substance use disorders in rural areas aren't better, they're not worse, they're just different. And there are some unique challenges, but often their smaller size actually allows individuals to make a big difference. And there are really very few communities, no matter what size, that are offering enough access to evidence-based treatment, especially the highest risk patients, you know, in the criminal justice system or IV drug users in syringe services program. And so I just encourage everybody to try to make their community the first that has enough access. I put a couple further reading pieces on here. The first one is about whiteness and war on drugs. It's just kind of an interesting look at the challenges around this. And then the second one is, it's mistitled. It's not really about, I mean, sort of about inappropriate prescribing, but this was really a journalistic piece done by this guy who actually came and spent some time in one of the communities that I'm familiar with in Western Washington. And it really gives an interesting look at how, you know, a few active community members, a few public health people, a police chief, someone in the court system, just a few people in key roles can really change a community perspective on substance use disorders and destigmatizing and really working towards a harm reduction model in the way we take care of people. So I think that's it, and I'm hoping there will be a little time for some questions, and I'm gonna pop out of this sharing my slides, so maybe I can see if there's any comments, or maybe Emily has some stuff for me.
So no comments quite yet. I don't know if you're able to just put up the CME information. It's okay if it doesn't take your whole screen, just so people can have access to that while we're talking. Keith shared an update for us with the U of M ER. They're making progress towards being able to do the buprenorphine and the ED. They have 5 ER docs waivered, early still, but they're continuing to build the program.
If I'd known there was a U of M person on there, I wouldn't have said that.
Here, you can stop sharing your screen. I'll share mine, and that way you can see questions as they come in. You're in charge of the chat box now, Chris. I can't see it.
Got it. Okay. So, oh, we got a nice group of people from all over. Excellent. And then, yeah, and Keith said, talked about the progress that they're making in U of M. No offense taken. All right. I'd be curious to hear if anyone else has, any examples of things that have really worked in their communities, either to decrease stigma or improve access, or any examples in drug courts or jails of things that are working out well. Oh, Patty asked a good question. with the coronavirus crisis, we've all learned to work from a distance. Any ideas on how we can reach into these areas and do distance work with the SUD population? Short answer is like, no, I don't have a great idea. But I've been doing some tele stuff with people. I know Sheba Sethi, who's one of the other opioid collaborative people, is doing a lot of telehealth. And obviously we have some for-profit companies, Work It and these other ones. I think there was, you know, for a long time, it was pretty much impossible for a lot of systems just because of the restrictions on on prescribing without face-to-face visits. But I'm really hopeful that they're going to keep some of those loosened restrictions in place, because I do think that makes a big difference. I think if there's a way to somehow integrate it with some telecounseling, that'll be a trick. But as a lot of you know better than I do, you know, broadband's an issue in a lot of places. I just tried to do a visit the other day on someone who, you know, no internet, out of minutes, you know, phone's not working. So all those things will continue to be a big issue. I think it's a good reason to continue to push for really broad broadband across all of our rural communities for both, you know, mostly for educational issues, but I think a side benefit would be around substance use treatment. Makes me a little nervous that nobody has any really good stories to share. I was hoping someone's going to tell me that something is working really, really great where they are. Oh, that's a good one. So yeah, Northwest Michigan Health Service, they have a collaboration with their CMA, their community mental health, that combines Vivitrol, the long-acting naltrexone, and SUD counseling services. So that's a cool one. Yeah, I think, you know, a lot of times small places can set up more personal collaborative care than, you know, I don't get to see people face to face. I'm in a bigger system now. You send them little notes and things, but I miss actually working in a smaller place where I could text everybody and everybody knew everybody, because I do think you can get things done that way. Yeah, and Julie works for Blue Cross Blue Shield, and obviously they've made a really significant investment in expanding outpatient based buprenorphine treatment across primary care. I didn't really get into that, but I probably should have. I can just give like an example, which is, so like I worked at an FQHC where for many years we had one provider who prescribed buprenorphine. And in the last 3 years, we went from having one person to now we have everybody waivered. So we have 12 providers. And now they went from having a handful of patients to a nurse managed buprenorphine program that serves a few hundred patients with fast track linkages from jail, from the syringe services program, in and out of the ED directly to the FQHC. And so I think Julie highlights a main crux of it is you have to have a critical mass of people who can offer evidence-based treatment. Doesn't matter as much what setting they're in, but there has to be a critical mass so people have somewhere to go. Well, great. Emily, if you have any other things, we'll stop a little bit early. I'll probably stay in the chat in case anybody has any other things that pop up. I don't know if you have anything else you'd like to say to people.
I just want to thank everybody for echoing, Chris. How do we mute you?
I got it.
Thank you. So I want to thank everybody for attending today. We like to be able to offer these webinars to you, so keep an eye out. There will be a survey of what you thought of this webinar, and also have the opportunity to give feedback to Dr. Frank and suggestions for future webinars. Again, if you're interested in receiving information on our webinars and you're not already on our email list, please be sure to put your contact information in the chat box. Otherwise, we will stay on for a little bit longer to answer any lingering questions or continue to share what folks are doing across the state.
Oh, there's been a couple other good comments that some of you can see. So FQHC from Christina that's offering buprenorphine and behavioral health. And there are a lot of incentives inside the FQHC system for offering care for patients with dual diagnoses. So that's cool. And I know that up in the UP, they've had a really dramatic increase in the number of providers that are interested in engaging with this population. Still work to do in the jails and the drug courts. That sounds that sounds right. I will say that the jails I've worked with that have instituted buprenorphine programs are all very happy that they have done it. And a big part of that is, you know, I mean, I don't know, the jail in our town was like the biggest detox center, essentially. There's just people, there's like 100 people withdrawing all the time. And transitioning people to buprenorphine took so much misery out of that entire environment that it was so much better for patients, better for the guards, staff, medical people. Anyways, it's way better. Oh, Mindy asked a good one. How do you recommend motivating rural primary care providers to want to provide MAT? You know, some of it's going to be generational change, right? I just did one of the waiver trainings for our entire intern class coming in, started residency, and more residencies do that. Sometimes it's going to be hard to take someone who is older and may not be, you know, full practice and may not want to learn anything to do that. But I always encourage people to you know, to send any of those people to the Opioid Collaborative, or you can always call the Opioid Collaborative. We do some academic detailing of practices for people. We give presentations because the evidence is like so clear that for most people, I mean, people with severe opioid use disorder just do not do well without some stabilization. And I know all of you see that, right? The people who come in and tell you they've been in detox 15 times, and, you know, like, I don't know what made someone think that the 15th time was going to work better than the 14th time, but the real motivating factor is when people see that it actually takes some of their difficult patients and stabilizes them and allows them to get back in the community, and they get a little success, and then the ball starts rolling. So I think having those providers talk to people who've done it and have incorporated in their practice, seeing that it's not a burden and it actually is a really rewarding part of their practice, I think that's the way to convince people one-on-one, just talking to them. Hey, that's cool. So Munson Medical Center has some people in their ER that are going to be prescribing and dispensing Narcan. Cool. You can tell that things are changing. I don't know. I feel it. I feel like the rhetoric 5 or 10 years ago compared to now is very different. Even in some places that I would have guessed would be very slow to change.
I'm going to go ahead and stop the recording.